Problem is I don't think a lot of these companies, a lot of these technologies have the burn rate and the capitalization to last long enough for the eventual arrival of value-based care. Because fee for service is easy. It doesn't require a whole lot of thinking. It's just the more you do, the more you make. And
Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Fun to be sitting here today with Dr. Vinod Dasa. Dr. Dasa is doing a ton of things. You probably see him all over your LinkedIn feed. If not him, then something from his platform, DocSocial. So super interesting there. Dr. Dasa is also 2 times LinkedIn top voice. Super cool. He's got the little tiny thing that comes down at the end of the LinkedIn box that makes all the difference. Dr. Dasa is an orthopedic surgeon, vice chair, professor, entrepreneur, innovator, and consultant. Dr. Dasa, thank you so much for sitting with us today.
sure, no problem. Thanks.
You're doing a ton of things. We're going to try to dig into it, but one of the things that we're going to try to do is kind of get into how you think as a person, as a leader, because obviously the theme is healthcare trailblazers, and obviously you're blazing a bunch of trails. I think that's yeah. So talk to us just quickly about where you grew up and why you chose medicine.
So I grew up kind of where you're calling me from. So I grew up in small area, not small, but area of Northeast Pennsylvania, just outside of Wilkes-Barre in a small town called Shavertown.
Yep.
So grew up there. I did my medical school and undergrad at Union College and Albany Medical College. So it was kind of a combined degree program. So I did that in 7 years, and then did my residency up in Buffalo. And then from Buffalo, did my fellowship in New York with the Insall Scott Kelly Institute. So that was kind of they're one of the pioneers in total knee replacement. And then ended up in Louisiana at LSU in New Orleans post Katrina. So I got recruited to come down here after Katrina with my wife. And you can imagine 2 years after Katrina, things are not necessarily, it's not a well-oiled machine.
Yeah.
So there was a lot of building, a lot of rebuilding, a lot of kind of figuring out what's going to work, what's not going to work. And so I kind of got thrown into the deep end right out of the gate.
Wow.
And I was sitting in boardrooms and making decisions, 3 months into my practice that probably people wouldn't be doing unless they were 10 or 15 years in. And so I got exposed to an aspect of healthcare almost from day one that most of us take years, if not decades, to get exposed to. So it really opened my eyes into how healthcare works and, you know, landmines and pitfalls and, trying to navigate the system, right? Because when you're right out from training, you just want to do a bunch of cases, you want to see a bunch of surgeries, get good at your craft, and kind of build a practice. I had to do that, plus build an academic department from scratch and be part of decision making that I was ill prepared to to be part of, but kind of had to learn on the job. So it was an interesting experience and time
Yeah,
thus far.
that's a lot. So I'm sure in addition to, so let's say you were 15, 20, 30 years down the line making those decisions. On the one hand, I'm sure you'd be a lot more experienced, but on the other hand, you'd probably also be jaded to a certain extent already and kind of just have a different perspective. How do you think you being plunged into that environment so early on did it give you any kind of edge in your opinion?
Yeah, I think it did in the sense that I knew how and why healthcare functions early. So I lost that naivete
Okay.
and that kind of, I don't want to say optimism, but I kind of got a dose of reality right out of the gate. So before, it almost prevented me from getting jaded in a
Hmm.
way because I wasn't in a bubble and then that bubble got
Hmm.
burst. I never had an opportunity to be in a bubble. um, and yet I wasn't protected from anything. So I grew up kind of in the rough and tumble. Um, So I haven't been jaded. What it did was open my eyes to how healthcare actually functions, which enabled me to kind of get engaged and be part of things that I don't think I would have, because like you said, I would have been jaded,
Yeah.
right? And just bitter and bah humbug type
Yeah.
stuff. But
Yeah.
I didn't have a chance to see the I in a kind of a weird way. I didn't have the chance to see the positive, so I knew what the negative was. I just grew up out of the gate. This is just how it is.
That's so interesting. And and so unfortunately, as much as healthcare functions, it's almost equally or greater so dysfunctions. Was
Right.
that not like to be thrown into it? So with your eyes being able to be opened by just being in those experiences, um, first of all, if you could share any particular experience where you were like, "What am I doing here?"
Yeah, so I got called into a kind of a board meeting, I guess. It's a big wood table with leather chairs all around it, right? So you're like, all right, a long table. So I got asked probably I think it was like within the first 6 months of getting there, to be part of an RFP run by supply chain to decide what total joint implants are going to be within a large health system down here,
And you're how
the
old at
biggest
this
health
point?
system. I am 6 months into my
Wow.
practice, and there's no other orthopedic surgeons. Everyone's gone. It's post
Right.
Katrina, right? And so I'm coming right out of fellowship. I'm trying to figure out where to park, let alone. So I'm in this meeting, and they're saying, this is an RFP. I'm like, well, what's an RFP? Number one, and then number two, what is supply chain? Like, I didn't. I missed that day in med school. I guess I must have been absent or sick that
Now,
day.
did you actually ask
So
those questions at the meeting?
I
Good.
did. Yeah, I
Good.
said
Good.
what, you know, um, and I had no idea how we select I just, I, just, I show up to the OR as a medical student, resident, or fellow, and we have
Right.
implants, right? We have
Right.
instruments. You just do it, right? I didn't see. I don't. We're never exposed to the sausage making of healthcare. So we're naive and blind to that, and so when I got exposed to that on day one, now you have an appreciation of how implants or whatever technology innovations, whatever gets accepted into a health system. You know, I didn't take it for granted anymore, right? Let's say I wasn't exposed to that, and I'd been in practice, and I used my implant, that I grew up with fellowship and residency, and I was good at it. And I wanted to switch to another company 2, 3, 5 years later, and I can't because it's not on contract. I'm going to pull my hair. I don't understand why it's on it. It should be here. We should have access to, but I knew out of the gate exactly how this functions now,
Mm,
right? And I knew this. So I don't get upset down the road because I know how the system works, right? From day
yeah.
one, as opposed to just being oblivious and blind
Just
to
being
it and
like,
just
"Where's my
saying,
Amazon
I should
order?"
have everything. Right, exactly. So, and so they're looking at me, and I've got these big wigs from Stryker and Depew and Zimmer Biomet, all these national whatever sales leader I couldn't even understand the titles.
Yeah.
And you got the head of supply chain sitting at the end of the table, and they're all like, we think implants should be priced this way or have this contract that, and then everyone looks at me. I'm like, are you kidding? Like, I don't even think I was like, I don't even think I've done a surgery yet.
Okay. Okay.
And
I have to pause you because most people in that scenario would immediately suffer from an extreme case of imposter syndrome and react by trying to make as if they know everything instead of going the route that you went, which is just be super genuine and say, "Hey, ask those questions that may have been that you. I'm sure your brain thought like this is an elementary question. What compelled you to take that route and not just be like, oh, yeah,
well, the problem is I couldn't even have imposter syndrome because everyone knew I just started 3 months ago, right? So I couldn't even pretend I
I
knew
guess
because so if I was 5 years, 10 years into this and I was in the meeting and was clueless, yeah, but I couldn't even try to be an imposter because it was just there was no way, that I would know this, and they knew I
right,
didn't know
right,
it.
right.
Um, so that was what was nice about it. I didn't have to pretend. I didn't have to be something I wasn't because they knew I didn't want to be
Yeah,
there. They knew I wasn't capable of being
got
there,
it.
but they needed a physician with some amount of knowledge to be able to, you know, to
That's
talk.
crazy. So you came to the realization that as little knowledge as you had the most knowledge in the room for that particular decision.
Exactly, which was
Probably
crazy.
terrifying.
So tell me what other scenario am I gonna, you're gonna get that? This is post Katrina, so that was kind of like, and that was the other thing. It was post Katrina, so it was kind of like, this is what we got. You're stuck with Dasa. This is
That-
make the best of it.
That's amazing.
So
Wow.
so it was, that's just one example of probably
Yeah,
dozens of how I had to grow up very quickly and understand how the system worked.
that's amazing. Now that you're
So
now that you're that mm, many more years into your career, looking back, how do you rate young Dasa in that in that boardroom?
I think I did good. I think I did well. I held my own. It led to a lot of innovative things that we've done here at Oshner and LSU. We had a startup that we were able to develop with technology, and that kind of those relationships and the way I thought, and people could see how I was thinking, started in that room,
Mm,
and then carried through. Years later when people kind of knew who I was and what I was thinking, and when new ideas came up, they're like, "Hey, Dasa thinks weird. Let's call him and see what he thinks about this."
that's awesome. And you're still there, right? You're still at LSU.
Yeah, I'm at LSU, but I do bulk of my clinical work at Oshner.
Okay.
But all my academic work, research and teaching and all that is with LSU. Yeah.
I think that's awesome though, because I wouldn't say everyone gets the opportunity that you got, but I'm sure there's a lot of variations of that opportunity that's presented to people, and it takes a certain individual and a certain personality type and a certain level of humility coupled with confidence, probably, to actually step into that role and then turn it into an amplify and an accelerator for your career. I'm sure a lot of people just like kind of buckle. So I'm just like, yeah, I'm impressed that you really stepped into those shoes.
Yeah, I mean, I guess there are two ways. I could have said no and just say, I'm busy or whatever. But I was just
Yeah.
curious. I was just, you know, when else am I ever going to be asked or have this opportunity? So I was just like, let's see what it's all
Yeah.
about. No idea.
And is your family medical? Were your folks in medicine at all?
Yeah. So my father was an anesthesiologist at Wilkes-Barre
Oh, no
General,
way. Right down the road.
and my mom, yep, and my mom was a physiatrist at John Hines.
Wow. So you
So, so both my
had a little
parents.
nudge in that direction, probably.
Yeah, I was brought up around it, and as a my parents were immigrants, and I think the expectations for the first generation are very
Yeah.
high because they're they come to the U.S. with
Yep.
nothing, and so they have high very high expectations of
Especially when they
their
become when
first
he
generation.
becomes a doctor in with nothing.
So so they're scared, right? So they really push you to do well and push yourself, and failure is not an
Right.
option, and you need to reach for the stars. So my parents, they were physicians. I grew up around it, and they had extremely high expectations, and it was kind of there were very few options for me in terms of what would make my parents happy, because when you're first generation like that, part of almost everything you do is to make your parents happy and ensure that their sacrifices coming here were justified and worth
Yeah.
it, right? So you have a lot of pressure to be successful however way you want to define it. And so growing up in medicine, becoming a physician and an orthopedic surgeon at that, that 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 was kind of just like an expectation because I didn't want to let them down.
Wow.
They gave up too much to come here.
Did you view that? Did you view yourself like that as well? Did you just view that as an expectation from yourself to go that far, or did you realize that whatever tiny percentage of the population actually ends up becoming a successful orthopedic surgeon?
Yeah, I mean, I don't think I appreciated that.
Yeah.
I think it was, both my parents are physicians, and if they can figure it out, then how the heck can I not figure it
Yeah.
out,
Yeah.
right? So to me, it was almost the bare minimum because they set the bar there, so I have to go above it, right? I mean, geez, I can't come below for everything they've done for me and what they've
You
done.
can't just become an
Uh,
accountant or a lawyer.
yeah, so they set the floor, right? So I had to at least equal that, if not, super go above it. So yeah, and honestly, medicine's safe, right? I mean, compared to a lot of other professions, if you can make it through, there's a ton of upside and a lot less risk compared to a lot of other professions, right? In terms of security and stability and uh, value and salary and all those things. So it's a it's a profession that really can withstand the test of time and good and bad.
Yeah. So throughout your career, what are kind of some innovations? Obviously, the central theme of this podcast is value-based care as a model, and we're moving that direction as a country. But there's a lot of micro things going on. What are some interesting innovations to you in the orthopedic surgery world um, that you maybe want to see more of, or maybe even some failures that you thought may have been interesting and then turned out to not be the case?
Yeah, so value-based care is an interesting concept. It We all want it to move faster, but it's moving at the rate of molasses. And if I look at kind of my life, or last 10 years, for example, right? The what's moving me forward isn't necessarily value-based care in and of itself. It's our measurement of quality and the level of transparency and accountability that we have now than what we had 5 years ago, 10 years ago, or 15 years ago. So value-based care kind of is represents that transition because in a fee-for-service model, right, a lot of things just get brushed under the rug or people don't care about or even know about, right? Because it's just the more you do, the more you make, and that's that. But as we start to measure quality, that fits hat in hand with value-based care because you got to measure quality before you pay for it, right? You can't just say I'm
Right.
paying for quality and not know how you what quality even means.
Right.
And what quality means to the patient is different than what it means to the physician, which is different what it means to the hospital and the payer and the government and on and on and
Right.
on. And so when we talk about value-based care, it's very challenging because we don't necessarily know what that means either. We just know fee for service and paying for volume isn't the way to
Yeah.
go, or may not be the right model. Maybe it is, maybe it isn't, and maybe certain circumstances it makes sense, and other circumstances it doesn't. Um, so the innovations, and I think that are coming down the pike are improving quality, all the different ways we can improve and measure and analyze quality.
Yeah.
But the problem is I don't think a lot of these companies, a lot of these technologies have the burn rate and the capitalization to last long enough for for the eventual arrival of value-based care because fee for service is easy, right? For on everybody's part. It doesn't require a whole lot of thinking. It's just the more you do, the more you make, and there are very few barriers to success with that mentality, right? For value-based care, that's a very heavy lift. It requires care coordination. It requires people working
Yeah.
together, teamwork, measuring, following, all the stuff that we're not good at, right? Fee for service model created a culture and an infrastructure that doesn't do all that.
Yeah.
And it's going to take a long time to change that culture.
Yeah. I guess the only point I'd raise is that, and maybe it's a what comes first, the chicken or the egg question, but I think without at least conceptual value based care, there's no incentive to even begin measuring quality. Like if you're fully comfortable in a fee for service world, then why even start? Why go in that direction? Right?
Correct.
Yeah.
Correct. Um, and the other thing is if we're okay, let's say we're 95% success, 90% successful at something,
Okay.
right? However way you want to define it. So we're so we're going to pay what for the 90% that we're already good at, and we're not going to pay, or we're going to reduce payment for the 10% that we're not good at. So is there enough juice here to motivate everybody to go after the money that's on the table for that 10%,
Mm.
right? Since we're already 90% good, and we're going to deploy all these resources and all these technologies and people and all this stuff to chase that 10%. Um, but we've got to start somewhere. And really, if you want to move the needle like this, the only real entity that can do this is a government mandate, right? That's the only reason we're using Epic and we're using the EMR. If it wasn't for the government, we'd all still be on paper right
Yeah.
now. For all the benefits paper and digital has, we would have never switched if it wasn't for the government and their incentives. Meaningful use and all the stuff that got put into the ACA. So for value-based care to stick, and I think to move forward, and it's a fundamental sea change of how we think and how we do business, right? Just like the EMR is. And I don't think it's going to be a market-driven approach. It's going to have to be a heavy
Mm-hmm.
hand from the government that says, and you saw it in orthopedics, right, with bundle payments and BPCI and all that, but it's drifted backwards. A lot of surgeons are not buying into it anymore
Interesting.
because they got burned.
Really? So
Yeah.
they couldn't execute on a good strategy that would have made the money in a value based care arrangement and a risk taking.
Well, it's a race to the bottom,
Yeah.
right? So at some point, there's only so much care I can improve, right? And then what happens?
So that's a question that I've raised to a bunch of VBC people, and the answer that I got that seemed to make sense to me is that, because that's what I said. I said, okay, so let's take a easy value based care arrangement, right? Surgery cost me. We decide that the benchmark for the surgery is $100. If I can spend less than that, we'll split it. Let's say some sort of cost sharing agreement, right? Okay. But in 5 years, you rerun the data, and because I've done so well and now I got it down to $50, right? And so now we run the data in 5 years. Now you're like, well, and actually the benchmark is now $50 because that's what it's really costing. Now it's like, okay, let me try to figure out how to do this for 30, right? And so that was my question to some people. The answer that I got, which seemed to make sense, is that the benchmark will always include a larger data set than what you've been successful at. So first of all, you have patients that are coming into, let's say, Medicare that have or coming into basically there's always going to be some sort of history data with this historic data with whatever condition you're trying to manage or whatever procedure you're trying to get down in cost that is going to inform the benchmark more than just eating yourself down to the bottom. Does that make sense to you or no?
Yeah, but I think what you're starting to see is us changing the scope, right? So before the whole idea was total joints, hips and knees, hips and knees, hips and knees, race to the bottom, squeeze the cost out, and like you said, now we're 10 years into it, and okay, there's no more water here to squeeze out of the stone.
Yeah.
So what are you seeing now? You're seeing a pivot to condition-based bundles. So now we're going to start looking at more population management than we are a specific patient and that particular episode. What value-based care is essentially shifting is we're turning into quasi-insurance companies.
Yeah.
Right?
Yeah. We kind of assume the risk and try to, and yeah.
So, so the insurance company will just be a claims processing type entity, right? And I'm bearing the risk, and I'm bearing, the mechanics of, understanding what the cost structure is and what the incentives are. Or the insurance companies take on the providers,
as in buy the
right?
providers.
And they start being completely integrated, vertical integration all the way up and down and horizontal. I mean, every which way. I wouldn't be surprised if United buys an implant company soon, or maybe even a pharmaceutical company too.
Do you see that as a plus or a minus?
United?
In general, do you see if what you just described, where basically one way or another the line between insurance and physician basically blurs completely? Do you see that as a good thing or a bad thing?
It's good and bad depending on whose perspective you're looking at it from. Right. So, for example, if I'm a large,
all that matters.
If you're a patient, right, I think integration is better. Right. But where it sometimes falls apart is these networks and who's allowed in and who's, so if you're a large IDN, large health system, and you have an insurance product and you're going at risk with let's say you have a Medicare Advantage plan or whatever, and you're fully at risk for all these lives that you're managing, you want all that money you need to keep in house, right? So you need to have home health, and you need to have the physicians, and then you control everything, right? The pharmacy and everything. But what it doesn't necessarily allow you to do, but let's say your providers in your health system are okay, but they're not great, right? So if I'm a patient, let's say I'm a 70-year-old patient that needs a knee replacement, if my Medicare Advantage plan is locked into this health system,
Yep.
and everyone in the health system has, I'm just making up a thing. Someday we'll get to a scoring system, right? A B
Mm-hmm.
plus, right? Everyone in that health system is a B plus, but there's a physician down the road that's got an A minus. I can't access that
Right.
physician,
Mm-hmm.
right? So it's got to be in such a way, ideally. So from a physician's perspective, it can be cush or it can be bad too, right? Because if you're not any good, you're bringing risk, you're out of
Right.
here. Whereas in a fee for service model, doesn't matter if you're good or bad,
Right.
right? Just
Right.
cut and everybody's
Yeah.
happy. Um, Whereas if you're a patient, even me right now or you, let's say your kid needs tonsils or whatever, right? Or tooth. Which dentist do you go to? Which ENT doctor do you go
Mm-hmm.
to? I'm in the business, I have no clue,
Right.
right? I have to ask
Yeah.
around, and all of that's word of
Yeah.
mouth. It's not even like some objective, data point that I'm saying, oh, you're the best tonsil, pediatric tonsil, tonsillectomy
Yep.
surgeon. Um, so it's very opaque. So I think right now it's not good for a patient. They're flying blind. So at least in a value-based model, there's some transparency and objectivity to figuring it out. Now the challenge with that is we talk about health disparities, right? So if we're measuring quality and we don't properly risk adjust for it, then we end up with lemon dropping and cherry picking, right? Because I'm at risk, so I don't want patients that are going to financially uh, jeopardize our enterprise. So I'm not going to take care of the sick patients or the patients that don't know how to use technology or can't. Because if I'm going to get dinged, so for example, if I have a patient that we need to capture quality data on 1 year after surgery, and they don't have Wi-Fi or they don't know how to use technology or they don't, so now I'm at risk because I didn't capture the data,
Right. Right.
right? Or you've got diabetes, hypertension, obesity, you increase the risk by 2%. So in a value-based model, I'm busy. I don't need you. I
Well,
got plenty of other
in your
patients.
mind, does that drive me to drop that cohort of patients, or does that drive me to figure out how do I get these guys Wi-Fi?
It could be either,
Yeah.
right? At an institutional level, how do I figure out how to get Wi-Fi? At the individual physician level, I'm dropping,
Right. 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 Right.
right? So if I'm busy, so let's say I'm a busy orthopedic surgeon, I'm booked out 3, 6, 9 months, whatever it is. Then why do I need to take on that risk when I've got all these other low risk
Yeah.
patients? I can afford to say no.
So it seems to me, but it seems to me, and I think you obviously bring up some great points, but it seems to me that the biggest success, the biggest chance for success for value-based care is really at scale, because when you have significant scale, first of all, and you might have to be good with really breaking down your data, right? But if you can do both of those things, then you can probably do some good. But the smaller that your patient volume gets, right? To your point, if I'm an individual doc and I've got two patients, right, and one doesn't have transportation, doesn't have Wi-Fi, really annoying, also got all these comorbidities and problems, and the other one also has the problems, which is a good thing for me because there's a lot of, like you said, water there for me to squeeze. But they're going to be they're going to have a better chance of actually coming through and adhering to their to my medical advice, then
Protocols and
I'm going to
yeah.
keep patient A and drop patient B, right? But if I'm a system with, you know, 30, I don't know, 100, whatever it is, 300,000 patients, whatever the, typical, and um, and I'm going to break down my data, I can say, okay, here's this bigger problem of all these patients without Wi-Fi. If I could just solve that, then I could increase, I could bring my costs down. I could reach these various milestones and benchmarks. And would you agree with that?
Yeah, and so if I'm a large health system, I got that many lives. This is where AI and all these technologies can potentially be extremely powerful, right? Because you can steer patients to the appropriate level of care. So let's say I analyze Dr. X and Dr. Y, right? Dr. X is both are great surgeons, but this surgeon has a great outcomes, especially in obese patients with
Yep.
diabetes, for whatever reason. I mean, who knows what they're doing, right? And this other doctor, maybe not so great, but does fine with all these other
Yeah.
patients. Well, then you know what? Let's move again. And both doctors are going to get paid the same, or they get paid such that there's no real issue in terms of them saying yes or no to any of the patients. then let's get the tougher patients, the harder patients over to this doctor that we know does well with
Mm-hmm.
them. And it's not at the detriment of the other doctor. We're going to send him these other
Right.
patients, right? Because that's where you're good at. Or this hospital is great at this. In our health system, we've got 10 hospitals. This one's doing extremely well with this, but not so. This is better for women's health.
Mm-hmm.
This hospital looks like they're much better at general
Right.
surgery. Let's, so that's to me where value-based care really kicks
Yeah.
in, is when we start aligning patients with the level of quality and the outcomes and the resources within that health system. So that's why I agree with you at scale, if we can do, and allows us to effectively deploy those
Yeah.
resources,
Yep.
right? So, and we don't have to waste money unnecessarily doing things we don't necessarily need to do.
Yeah.
Um, problem is fee for service is easy. It's just
Right.
easy,
It's 1+1 = 2.
right?
Yeah.
That's and so and there's no
Right.
thinking. It's just
Right.
so that's why I to a certain extent I like fee for service because I don't have to worry.
Right. Right. There's so much that we could get through. Let's go. I want to touch on 2 points. Talk to us a little bit about DocSocial. What is that, and why are you passionate about it to the extent that at least I see you post about it all the time?
Yeah, so DocSocial was a platform that we created with Alok Sharan, David Flickinger, and Justin Martin. This came out of COVID. So Alok is created a pretty innovative spine concept called Awake
Mm-hmm.
Spine, and basically opiate-free spine surgery, or minimizing enhanced outcomes and all that stuff. And so he was going to do a uh, cadaver lab, first cadaver lab in Seattle during COVID. We planned for it in May of COVID, and he asked me to be a part of that on the knee side, and talk about how to do opiate-free knee replacements and all that stuff. COVID hits, and he started thinking, well, all right, if this is the new world order here, and we're going to have to figure out how to teach people virtually, right? There's no more in-person cadaver labs and all this
Yeah.
stuff. So he created DocSocial with the intention of teaching surgeons how to basically substitute for an in-person, training. Um, and he came to me, or those guys came to me and said, "What do I think?" And I said, one thing that's missing here, and there are physician-only platforms all over the place, right? And I think that there's nothing disruptive or novel about that. But what I said, what's really needed is collaborative learning. So we need a platform where physicians and nurses and pharmacists and therapists and vendors and everyone is collaborating and learning together. Because if you look, value-based care and all this other stuff, decisions are now made
Yep.
collaboratively. It's not just the surgeon thumping their chest saying, I want A, B, and C
Yep.
anymore. It's kind of a group dynamic now. And so I told him I think we should create a platform that's open to all healthcare professionals so they can learn together. Because if you want to convince healthcare about a certain idea or theme, you've got to talk to a broad, multidisciplinary audience these days,
Yep.
right? Yeah, doctors are still important, and we're writing the prescriptions and doing all that. But it's not like it was 15, 20 years ago either,
Right.
right? There's a lot of others that are part of the decision making, purchasing, utilization, deployment process than just the physician anymore. And just ask any physician, they'll tell you they're losing autonomy. They'll tell you,
Yep.
I can't make decisions anymore,
Yep.
right? So you need a platform that's not physician only. You need a platform that's open to everybody, so you can learn and do whatever, together. So that was the genesis of DocSocial. It started doing during COVID, and it's grown nicely. It's grown steadily, and seeing the broad range of people joining.
Yeah.
Again, like I
How many
said,
people are on it?
chiropractors. I've got to look back. It's a lot. So we've got thousands of patients on it. I mean, not patients, thousands of people. So you know, it's been interesting. Again, like I said, pharmacists, therapists, business people, lawyers, physicians, reps. It's been
That's
cool.
awesome. That's really great.
Yeah.
Listen, maybe we'll have to do a part 2. I don't know, because there's so many thoughts to get through. But I really appreciate you spending time with us today. It's great to see you again, and best of continued success with your work over at LSU and with DocSocial and your various other endeavors. It's always nice to see somebody that's your energy's up, you're not Mr. Pessimist. You've got a good wrap around mentally about what's going on, and it's always nice to see that. So thanks for spending time.
You're welcome.